little hair means, and normal blood pressure. And we ask the question, what is the diagnosis? Hypopituitarism and the common causes, the diagnosis and treatment. Actually speaking, for every gland that we will discuss in the next presentations, usually we will focus for every gland for the hypofunction, hyperfunction, and also discuss any emergency. So keep in your mind that in the future, for every gland, for example, let's say for the thyroid gland, we should discuss the hyperfunction, the hyperthyroidism, and the hypofunction, hypothyroidism. And we should discuss any emergency, any clinical emergency concerning these glands. And the same will be applied now to the pituitary gland. But the big difference for the pituitary gland, it is a gland that secrete many hormones, more than one hormones. So we can imagine that we have more than one disease, more than one condition of hyper and hypofunction. It may be occur separately, or it may be occur in combination. Don't forget that we have said that the anterior pituitary gland usually secrete around 6 hormones. And also we have 2 hormones coming from the posterior pituitary gland. So for the hypopituitarism, it results from impaired production of one or more of the anterior pituitary trophic hormones. What are the causes? I will describe to you these causes. It's either inherited, but it is commonly acquired. It reflects the mass effect of tumors or the consequences of inflammation or vascular damage. So let's say the common causes are usually mass due to the presence of tumor or mass that will compress the anterior pituitary cells and result in hypofunctioning. But at the same time, the pituitary gland also can be affected by other disease, especially if there is inflammation or if there is infiltration or vascular damage. When hypopituitarism is accompanied by diabetes insipidus or hyperprolactinemia, one should also consider a hypothalamic etiology. This is an important point, and just to explain that, if you have a patient who presents with polyuria and polydipsia, and this can be caused by diabetes mellitus, but if the blood glucose is normal, you can presume that this is due to diabetes insipidus. And if this occurs, if this diagnosed, usually the disease is not limited to the pituitary. It is usually originated from the hypothalamus. And the reason is simple, because the ADH, the antidiuretic hormones, which is secreted from the posterior pituitary, usually come from the hypothalamus. So if we have deficiency of this hormone, this means that the defect usually, or the lesion, primarily involve the hypothalamus, because if it is only involved the pituitary, the hormones will continue to be secreted from the hypothalamus and no disease will occur. So what are the causes of anterior pituitary hormone deficiency? These are actually, you should keep in your mind that these are rare. Now, today, we are talking about rare condition. It is not so common. But you should think of this disorder, especially in people who have history of pituitary tumor previously, like, for example, pituitary disease or pituitary surgery or adenoma or hemorrhage. So in examination, if you see a case, if you have a case and the statement of previous pituitary disease is present or surgery, you can think of a possible pituitary hormone deficiency. So these are the common causes. This is from your textbook. Also, I want to remind you that your textbook for this course is mainly Davidson, Principles and Practice of Medicine, the last edition. Sometimes we may discuss some important points from other references, but your reference textbook, you should know, it is our college textbook, which is the Davidson Principles and Practice of Medicine. So this presentation usually comes from this textbook, and even these causes are present in your textbook. Always you can review the textbook. So you can see now there is astraxis, which means that these words in bold means these are the common causes. Structural causes, which means that there is something wrong with the size or the anatomy of the pituitary. It is either a primary pituitary tumor, which is adenoma. It is rarely carcinoma. Okay, so pituitary carcinoma is common. This is false. Usually it is rare. Or sometimes, rarely, it may be secondary tumor, which means that there may be involvement of the pituitary by other tumors. As I said, this is rare. Cranopharyngioma is common, especially in children, and meningioma. Okay, so these disorders, although in general they are rare, but these are the common in this rare disease. Okay, do you get the point? And also meningioma and Langerhans cell histiocytosis and hemorrhage. Langerhans cell histiocytosis is rare, but actually we have come across around 2 or 3 cases within the past 2 years, and the patient may present with Debs insipidus because this infiltrative disease usually involve the hypothalamus also and cause Debs insipidus plus features of hypopituitarism and also other involvement in the skin and bone and other tissue in the body. What are the inflammatory disorder? Sarcoidosis. Sometimes the pituitary may be also infected by infections like the tuberculosis, and also maybe hemochromatosis, which is an infiltrative disease, can also infiltrate the anterior pituitary. We have also congenital deficiencies like the Kalman syndrome, which is usually occur due to isolated gonadotrophin hormone releasing hormone deficiency. The pituitary gland also sometimes may be affected by functional, which is sometimes also common. For example, if you have a patient with severe anorexia nervosa, excessive exercise, this also can affect the function of the pituitary. As an example for this condition, you have a young girl who is dancing, for example, or practicing a special type of sports, like for example, gymnastic, etc. This girl also may have, for example, amenorrhea. And also I come across a young girl around 16 years old who comes to me in the previous year with amenorrhea. And she was thin, and on inquiry, on history, she was practicing some sort of dancing at home. She practiced the dancing every day, and her weight is thin, and so this can affect the pituitary function and may result in amenorrhea, for example, in women, or may have patients with severe systemic illness, which can affect of the pituitary. So think of any pituitary gland disorder in those people who suffer a chronic systemic illness, or maybe, for example, with some exercise which is excessive, and even, as I said, some type of sport. Head injury, this also may cause hypopituitarism, paracellular surgery, paracellular radiotherapy, and postpartum necrosis or Sheehan's syndrome. What is Sheehan's syndrome? Sheehan's syndrome is a condition that occurs due to hypovolemia. For example, especially occur in ladies postpartum hemorrhage. If these ladies develop severe hemorrhage after delivery, this severe bleeding will affect the vascular supply to the pituitary, and this can cause hypopituitarism. So here, the clinical scenario that you may come across a lady who have delivered before, let's say, few months, 2 months, 1 month, and present with amenorrhea or lethargy, weakness, and other features of hypopituitarism. And when you check, you discover that she has history of severe bleeding postpartum, and she had received a lot of blood to replace the anemia. So don't forget Sheehan's syndrome as a cause of hypopituitarism in in ladies postpartum after delivery. So now I will explain to you the clinical presentation of hypopituitarism, الأعراض الجانبية لخمول الغدة النخامية. How can people present if they develop نقص هرمونات الغدة النخامية? They can present with features of deficiency of one or more anterior pituitary hormones. The presentation is highly variable and depends on the underlying lesion, the age at onset. For example, if it develops in young girl, it can affect her menses. But if the condition occur at later age, post-menopausal, sure, there will be no effect on the menses. And also, the presentation will depends on hormone affected, speed of onset, how it is rapid or quick, and duration of the deficiency. Here I reach to a polling question. I would like to ask you this question. Which of the anterior pituitary hormone is first to be lost in hypopituitarism?
Dr. growth hormone?
TSH.
So A, growth hormone, B, TSH, C, ACTH, D, FSH. Let's see the growth hormone secretion is often the earliest to be lost, but a very important point, I would like to remind you that usually this occurs in cases of pituitary disease due to adenoma or mass, let's say compressive, which is the common. But sometimes if the pituitary gland affected by inflammation or infiltration, the sequences of hormone deficiency may differ. And some said that even sometimes the cortisol may be affected first. But today talk, I usually refer to these disorders mostly caused by pituitary tumors. What are the clinical features of adult growth hormone deficiency? You know, growth hormone deficiency in children will affect the stature, and the child may present with short stature. And I think this subject should be covered by the pediatric curriculum, as I hope so. So in adult, if adult with hypopituitarism, he or she may complain of growth hormone deficiency. And the clinical features of growth hormone deficiency will be listed here. I think you should keep this in your mind, because usually we don't always talk about the growth hormone in adults. So I think this is important slide. This, for example, may come in examination. So these are the clinical features of growth hormone deficiency: reduced muscle tone and power, increased fat. The person will be fatty with no mass, with no muscles, I mean, sorry. Easy fatigability, poor exercise, low mood, poor concentration and memory, and even can affect the bone, osteoporosis. And also it had been said that growth hormone deficiency in adults may also result in increased cardiovascular risk, maybe due to impaired endothelial function and other explanation. So what is the next hormone to be affected and to be lost is the gonadotropin, which are the luteinizing hormone, LH, and follicular stimulating hormone, FSH. And this will cause in male loss of libido, which means loss of sexual drive. And in female, it can affect her menses. The menstrual cycle either will be ceased or will be reduced. We call this oligoamenorrhea or amenorrhea. Later, with time, in the male, there may be gynecomastia and decreased frequency of shaving. Actually, sometimes even sweating is also common. And I will actually tell you about patient who present to me before around 6 months. He was around 63 years old. And actually, he present to me with sweating. He complained only of sweating. And on inquiry, he denies to tell me about the other features of pituitary hypofunction. But when I assess, by the hormone assess, I discovered that this man has low testosterone. And then on imaging, actually, I have discovered a large pituitary mass. He has pituitary macroadenoma. Also, in both sexes, just to remind you that even the hot flashes which occur in women after menopause can occur in men who have deficient testosterone level. They also may sweat, the male may sweat, according to this case. In both sexes, axillary and pubic hair eventually become sparse or even absent. So after the gonadotropins, what is lost next? It is the ACTH, which result in cortisol deficiency. And this deficiency will lead to striking degree of pallor, which is principally occur due to lack of stimulation of melanocyte by the beta lipotrophic hormones. To remind you that ACTH hormone have some molecule or subunit with similar structure, and this function to stimulate the melanocyte to produce the normal pigmentation. So you can say that patient with low ACTH may express severe pallor, not due to anemia, but due to low ACTH. And this is a common question. Always we ask the question, we ask the students in medicine, what are the causes of pallor? The answer will be immediately anemia, sir. And I ask then, what else? So many students will stop answering. What else can cause pallor? And here today, now you have another cause for pallor, which is the central hypoadrenalism due to low ACTH. Finally, TSH secretion is lost with consequent secondary to hypothyroidism. I would like to remind you that today, now I am talking about hypoadrenalism, خمول الغدة الكظرية, hypothyroidism, خمول الغدة الدرقية, which is usually secondary to hypopituitarism. Okay, so think always that when we are talking about hypofunction especially in the thyroid and in the adrenal gland, it is usually mainly primary, not secondary, but sometimes can occur secondary as consequences to hypopituitarism. And there is some difference when we talk about secondary or primary hypofunction. Another question for you: patient with Kalman syndrome commonly have A, blindness, E, anosmia or anosmia, deafness or muteness. What's your answer here? And this is actually caused because that the embryonic origin, the nerve origin is the same for the gonadotrophin and for the olfactory bulb. It will these nerves will migrate during the embryonic life from the site of olfactory or olfaction to the anterior pituitary. The same embryonic original for the gonadotrophin cells and for the olfactory bulb or olfaction cells. What is Kalman? Kalman, this is a name of science who discovered this syndrome. So there will be defective hypothalamic gonadotrophin releasing hormone synthesis. Okay, so here the defect in the hypothalamus usually, but it is isolated just for this line, which is the gonadotrophin releasing hormone synthesis. The patient also will present beside the hypogonadism due to low testosterone and low sex hormones due to low GnRH. The patient may present also, as I said, with anosmia or sometimes hyposmia, just reduction in the smell due to olfactory bulb agenesis or hypoplasia. Kalman syndrome may also be associated, but with lesser frequency, with color blindness, optic atrophy, nerve deafness, cleft palate, and kidney abnormalities. This is the picture for a young boy with Kalman syndrome. Usually, they are tall. And why they are tall? Anybody can answer me this question?
Dictating growth hormone gives that.
No, the growth hormone here is normal. Who said growth hormone is increased? It is normal. Why it is increased? Now I am talking about deficiency. احنا اليوم محاضرتنا كلها deficiency. ما عندنا زيادة اليوم. كلها deficient. And Kalman, as I said, it is usually caused by isolation. هنا اللي يصير بالكالمان عندي الديفكت والديفشنسي not all hormones. البقية ممكن تكون normal. But the deficiency here in the cells of gonadotrophins. احنا مو عرفنا انه the pituitary gland cells usually controlled by hypothalamic. وعندكم السلايد الموجود في المحاضرة تراجعوه دائما اللي يخلي I should go to this slide because I think it is important. Okay, this slide. You can see that the anterior pituitary hormones controlled by hypothalamic factors. Okay, and this is important in the examination. نعرف من هو البوزيتيف من النيجاتيف. For example, the let's see the gonadotrophins here in the Kalman. This will be deficient, so it will cause low LH, low FSH. So why they are tall? Simply because there will be deficiency of sex hormones, and the sex hormones usually is the hormone, especially the estrogen. It is the hormone that cause epiphyseal closure at the end plate of long bones. هو اللي يخفض العظم في العمر المحدد. When there is no estrogen, ماكو sex hormones, the long bone will continue to be elongated. It will not closed. ما راح تقفل، عظم ما يقفل، فيبقون إلى حد ما إلى عمر معين. They have a high stature, tall. And you can what is the else presenting sign in this image, in this excellent gynecomastia. أكيد الكوز due to low testosterone. And if you examine the testis of this boy, you will find it is small testis. They will have small testis. And the most important physical sign in assessing the low or the hypogonadism in males is the testicular size. So this is the one important feature for puberty. The testicular size, when you want to decide by examination that this boy have entered puberty, you should look for the testis. While in girls, what is the early sign of puberty? Who can answer this question? In male, the testes.
Amenorrhea.
No, I mean the sexual characters findings. The by
small breast.
examination.
Hair distribution يصير أزيد.
No. I am discussing with you the causes of hypopituitarism. احنا هسه كل هذا الكلام بدنا نحكي لحد الان حتى ما تتيهون، حتى ما تضيعون. انا بدي احكي لكم الكوزز اوف هايبو، لان زال احنا فوق بالهايبوبيتوتاريزم، لكن بدي ادخل في بعض التفاصيل حتى نعرف بعض الامبورتنت knowledge about these causes. احنا قلنا مره ثانيه this is rare but we have these common causes اللي بدنا نحكيها especially the tumors the adenoma. لا تنسون دائما الcommon cause of hypopituitarism هو اذا كان patient عنده pituitary especially if it is macro، اذا كانت كبيره or it is operated upon and had been removed, and we call the pituitary removal surgery what we call if the patient had underwent surgery. شو نسميها العمليه؟
hypophysiectomy.
Excellent. Hypophysiectomy. So another cause for hypopituitarism هي pituitary apoplexy. Apoplexy معناها النزف bleeding. It is acute intrapituitary hemorrhagic vascular events. It is a little bit surgical issue. May occur spontaneously in a pre-existing adenoma. Patient and the adenoma may develop hemorrhage. It also postpartum Sheehan syndrome. Sheehan syndrome. Usually it is a common question in examination. Sheehan syndrome. أكيد عرفتوها شنو هي postpartum bleeding اللي يسوي لك يأثر على يسوي hypovolemia ويأثر على blood supply to the pituitary وراح تروح يصير بيها necrosis البيتوتري الانتيريور بيتوتري طبعا يصير بيها necrosis يعني infarction فيصير عندهم هايبو عادة تكون طبعا permanent والبيشنت يحتاجون replacement as any case for hypopituitarism. This condition also pituitary apoplexy may occur in association with diabetes, hypertension, sickle cell, or acute shock. Usually this is an acute emergency. So here we have the first endocrine emergency, which is the pituitary apoplexy. And for every gland, I will explain to you the emergency in that gland. For example, toxicosis may cause tardive hypothyroidism may cause myxedema coma, adrenal crisis, etc., hypercalcemic crisis, the parathyroid. So here in the pituitary, we have this emergency, pituitary apoplexy. هنا الكلينيكال سيناريو كالآتي ممكن يجيك بالامتحان انه patient known to have pituitary macroadenoma وكانت زين وستيبل on treatment suddenly come to emergency جوال الطوارئ عندها hypoglycemia hypotension وايضا severe loss of consciousness. فشنو البوسيبيلتي هنا؟ ممكن احنا نقول she may develop for example apoplexy يعني simply عندها mass او عندها mass pituitary adenoma may be large and this may be bleed ممكن يصير بها bleeding or hemorrhage and the patient may present with such emergency which need urgent surgical intervention. This is MRI. This is an MRI image and you can see here اللون الوايت يعني tense بيضة تصير. This is due to blood bleeding in the anterior pituitary صارت كلها كتلة بيضاء due to bleeding. هنا إذا تشوفون أقل bleeding لكنه موجود أيضا شوف إنه أكو pituitary هي كبيرة على البيتوتري ماكرو أدينوما وبيها أيضا hemorrhages الوايت streaks. This patient with pituitary apoplexy may present, as I said, with headache, meningeal irritation, visual changes of thermoplegia, cardiovascular collapse, and loss of consciousness. The CT or MRI may reveal signs of intratumor or cellular hemorrhage, and those with significant or progressive visual loss or loss of consciousness require urgent surgical decompression. Next, we have another question for you. Which is the best test to diagnose secondary hypothyroidism? As I said, we are talking about always primary and secondary. And here, how can you diagnose secondary hypothyroidism? Or C3T4, D, TRH. Secondary hypothyroidism هو ممكن طبعا هو ممكن affected طبعا احنا يجونا البيشنت عادة all hormones may be affected then may present late. احنا بدنا نقول هذا sequence اللي يصير sequences if you detect these people early فممكن تمشي على هذا السيكونس، لكن ممكن يجيك بيشنت عنده كل الهرمونز ديفيشنت، فيصير عندهم خلينا نقول بان هايبو، نسميها بان هايبوبيتوتاريزم not isolated والهرمون. هنا طبعا nobody answered this question. The answer is طبعا هنا العفو اكو غلط، هو 3T3 3T4. هنا الانسر هو راح يكون 3T4. هاي 3 طبعا. هنا نشخص بال 3T4 وليس التي اس اتش، والسبب هسه راح نشوف ليش. Okay, how can we investigate patients with pituitary and hypothalamic disease to identify patient with hormone deficiency؟ ACTH deficiency راح نسوي سيناكتين تيست نسميه، او طبعا حاليا احنا ممكن نسوي early morning cortisol، نشوف اذا الكورتيزول low معناها there is deficient ACTH، ايضا يكون low ACTH، او نسوي ستيموليشن تيست باي نسميه احنا شورت سيناكتين تيست. هذا احنا كلنا طبعا بدنا نحكي حاليا بالسكندري، كل هاي التفاصيل راح نفصلها بعدين من نحكي على البرايمري ديس اوردر، بس انا ان جنرال راح نحكي موست اوف ذيس تيست. ال اتش اف اس اتش ديفيشنسي هذا يعني يوجوالي ما يحتاج دايناميك تيست. ان ميل تقيس الراندوم تستوستيرون، لكن يفضل يكون ايرلي مورنينج وفاستنج، البيشنت يكون يجيك فاستنج to measure the testosterone. The best time to measure the testosterone هو before 10 AM، قبل الصبح، يعني قبل 10 الصبح، ويكون الميل يكون البيشنت يكون فاستنج. ان بريمينوبوزال فيميل نسال على المنسز اذا كانت ريجولار. البوست مينوبوزال measure the serum LH and FSH. اوكي، التي اس اتش ديفشنسي هنا we will measure the free serum thyroxine اللي هو T4. And we should not test the TSH, which is usually the standard test in the primary. ما راح نوصل للثايرويد disorder I would remind you about this issue. راح اذكركم انه احنا بالبرايمري احنا عاده التيست اوف تشويس هو TSH except in cases of secondary hypothyroidism. هنا يكون التيست هو يكون ال T4. اوكي انا حاليا بدي اتكلم لكم على الانفستيجيشن اوف هايبوبيتوتاريزم حتى ما تتيهون، حتى ما تضيعون. حكينا الكوزز، حكينا كلينيكال فيتشر، هسه شلون نشخص الهايبوبيتوتاريزم باي انفستيجيشن. تفضل يعني.
عفوا دكتور، بس التي اس اتش ليش نقيسها؟ لازم فاستنج
لا التستوستيرون نعم التستوستيرون، لانه التستوستيرون يوجوالي عاده يكون ايرلي مورنينج البيك مالته. التستوستيرون عاده الهرمون الذكري يكون ايرلي مورنينج، فانت من تقيسوه العصر ما راح تحصل البيك مالته، لان هو طبعا مالته الكونسليشن ما يكون ستيبل. واضح يعني؟
اي دكتور.
حكينا على الاي سي تي اتش والال اتش والتي اس اتش. الجروث هرمون طبعا احنا sometimes نحتاج انه نسوي له evaluation. Levels are commonly undetectable, so you should choose from a stimulation test. فاذا الجروث هرمون يحتاج stimulation دائما، يعني خلي هذا يعني اعطي لكم اياه كهوم ورك، تخلي كل هرمون وتخلي قباله انه I should test it. يحتاج دايناميك لو اقيسه عادي at any time، يعني قصدي ما يحتاج دايناميك تيست، يعني ما يحتاج سبريشن وما يحتاج ستيموليشن تيست. فمثلا تقول الثايرويد هرمون يحتاج لو ما يحتاج، يعني يحتاج دايناميك تيست لو لا التيست مالته يكون بدون دايناميك. مثلا تقول الجروث هرمون اقيسه دايناميكلي لو مو دايناميكلي. مره ثانيه اعيدها حتى تفهموها شنو معنى دايناميكلي. انا قصدي يجيك البيشنت يقول لك انا عندي نقص هرمون النمو دكتور سوي لي تحليل، هل انت راح تكتب له جروث هرمون ويروح سوي تعال؟ لا، هذا قصدي. بينما من يجيني عنده ثايرويد هرمون ممكن ما احتاج في الدايناميك تيست. الدايناميك تيست معناه احنا نستخدم سبيشال تيست بيها في مانوفر معينه، اما سبريشن او ستيموليشن، يعني الموضوع شويه معقد في بعض الهرمونات، فمن ضمنها الجروث هرمون، والبقيه عليكم اصفنوا بيها. واذا عندكم سؤال اسالوني بالكلاس روم اذا واحد صار عنده استفسار على which is which. الجروث هرمون اكيد ما يصير يجيك واحد خطيه طفل يعني قصير تقول له روح سوي لي جروث هرمون تعال هسه اركض سوي لي هرمون، ماكو هيك حكي طبعا. لازم يسوي له ستيموليشن باي كلونيدين او باي بوست اكسرسايز، هذه قدامكم حاليا، او ارجينين او جلوكاجون، فذول يحتاجون دايناميك تيست. طبعا يبقى احنا الستاندرد تيست هو الانسولين tolerance تيست، بس هذا التيست هو usually it is not routinely done. It assess the hypothalamic-pituitary adrenal axis. إذا تسألون يقول لك شنو الستاندرد تيست for the hypothalamic-pituitary axis؟ تقول هو ال ITT يسموه insulin tolerance test. It will also assessment of growth hormone deficiency indicated when there is doubt from other tests, usually performed in specialized centers. Intravenous glucose and hydrocortisone must be available. It should not be done. It is contraindicated in ischemic heart disease, in epilepsy, and in severe hypopituitarism. And it is usually done by insulin, which is given IV, and then you should test the hormones. Another question.
دكتور استخدمنا انسولين توليرانس تيست لانه الانسولين يشتغل سينكروني ويا الجروث هرمون، فلذلك نستخدمه يعني بالتيست.
احنا عادة هاي بعدين راح تعرفوها سؤال very important. This is a great question because insulin usually induce hypoglycemia, and hypoglycemia will trigger the release of many hormones which are in the growth hormone, the catecholamines, the cortisol. So this is usually done in order to trigger a release of these hormones. If these are deficient, there will be no release of these hormones. Which of the following is first to be replaced if deficient in case of hypopituitarism؟ معناها وصلنا للتريتمنت، فشنو البيست تريتمنت الفيرست to be replaced؟ A thyroid hormones، B cortisol، C growth hormone، D testosterone. عندك patient male patient عنده hypopituitarism وعندك deficiency these hormones، شنو البيست to be؟ So treatment cortisol replacement by hydrocortisone therapy should be given if there is ACTH deficiency. Here mineralocorticoid replacement is not required. Why? Because the function of the adrenal gland is not, which is the zona glomerulosa, is not controlled by the pituitary. It's controlled by the running aldosterone system, so it is not affected here. Thyroid hormone replacement, as I said, usually you need thyroxine, which is usually in high doses. Unlike in primary hypothyroidism, TSH, this is the answer for the previous question, TSH is not helpful in adjusting the replacement dose because patients with hypopituitarism often secrete glycoproteins which are measured in the TSH assay but are not bioactive. يعني بالhypopituitarism راح TSH ما راح يكون accurate، ما يكون دقيق، اكو فد نوع من الاسي انترفيرنس، مشكله بالاسي انترفيرنس، فدون ديبند اون تي اس اتش فقط بالهايبوبيتوتاريزم يعني بالسكندري هايبوثايروديزم تعتمد بالدايجنوسيس وبالفولو اب بالفري تي 4. الايم in hypothyroidism to maintain serum T4 in the upper part. It is dangerous to give thyroid replacement with adrenal insufficiency without first giving steroid, which is the first priority. Why? Because this may precipitate adrenal crisis. And pituitary failure, the only two hormones that must be replaced for survival are, anybody can answer this question? What are the two hormones which are essential?
دكتور T4.
cortisol, thyroxine.
You are both true. T4 and hydrocortisone, these are the essential, but as I said, hydrocortisone is the first to be supplied. It is important to ensure that the patient is adequately replaced with corticosteroid before starting T4. لا تنطي T4 حتى اذا كان deficient قبل لا تتاكد من الكورتيزول، لان قلنا اذا انطي T4 بدون كورتيزول، T4 تعرفون ثايروكسين it will increase the metabolism، فالبيشنت راح يصير عنده more and more cortisol deficiency and will develop adrenal crisis because thyroxine increase corticosteroid clearance. طبعا السكس هرمون اذا كان بالمين at any age يحتاجه، ف we can supply with gonadotrophins اذا كان فقط for the sexual function by نعطي androgen to prevent also osteoporosis and to restore the normal sexual function. Oral testosterone is not recommended because this is potentially hepatotoxic. هنا very important point that people men who receiving testosterone لازم نسوي follow up لانه عنده مشكله بالبروستات. It should not be used in CA prostate and in polycythemia for example. The PSA should be measured and also hematocrit الPCV لانه ممكن يسوي polycythemia التستوستيرون اندروجين. الجروث هرمون احنا مو دائما ننطيه بالادلت لكن sometimes may be given in special circumstances. It is also given to young على مود الجروث هرمون deficiency in kidney failure and internal syndrome. It may cause sometimes sodium retention cascade effects or carpal tunnel syndrome. And in this slide you can see in this table الهيدروكورتيزون دوز. احنا عاده البيست كورتيز يعني كورتيكوستيرويد ريبليسمنت هو الهيدروكورتيزون اللي هو اورال ثيرابي نعطي عاده الصبح وبوست بي ام. طبعا هاي بعدين نحكيها بالادرينال انسفشنسي محاضره كامله عليها. التي اس اتش نعطي ثايروكسين وقلنا على التستوستيرون. طبعا بالنسبه للتست يعني الميل او الفيميل احنا عاده اما نعطي سكس هرمونز فور ذا سكشوال فانكشن واذا كان القرار فور فيرتيليتي راح نعطي جونادوتروفينز نعطي البيتويتري او السنترال هرمونز. اذا كان البيشنت ديفلوب داز انسيبيدس اللي لها محاضره خاصه نعطي فاسوبريسين. We reach to the end of